very good morning to all the doctors, students who have logged in today's exciting webinar from not only the country but also across the world. This webinar is brought to you by Mumbai Hematology Group and supported by Intas Oncology. Today's topic is on BTKi for clinical hematologists from first generation to third generation. Now, uh, we all know about Professor Dr. M.B. Agarwal sir. Now, actually, last week also we discussed about this webinar series, which has completed 5 years non-stop every weekend. And what to say, I think this is the longest webinar series on hematology, or may not be not only in the field of hematology, but across all therapies, which is running non-stop. And we owe a lot uh, to Professor Dr. M.B. Garwal sir. He is an institution in himself and inspiration for many. And I think not only in the field of hematology, a lot to learn about life also from sir. So um, thank you so much, sir, for actually creating platforms so that everyone, not only in the country but across the world, is abreast about the latest advances in the field of hematology. And uh, now I would request sir to take the proceedings forward.
Thank you, Mr. Ashish, for those kind words. Good morning to one and all. Guest speaker today is Dr. Satish Kumar A. from Bangalore. He'll be speaking on BTK inhibitors for clinical hematologists from first generation to the third generation. This webinar is brought to you by Mumbai Hematology Group. It is supported by Intas Oncology and managed by Perfect Square. I'm grateful to Dr. Manoj Kumar, Mr. Arun Hegde, Mr. Ashish Shah and the team from Intas, Mr. Yash, Mr. Kalpesh and team from Perfect Square, the Executive Committee of Mumbai Hematology Group. I'm pleased to inform you that Dr. Mukul Agarwal from Hematology Department, AIMS Delhi, is our chief guest today. And of course, our guest speaker, Dr. Satish Kumar A. from Bangalore. All our discussants who are eminent hematologists, medical oncologists, and you participants for sparing your Sunday morning if you are logged in from India, and afternoon or evening for those who are logged in from the other part of the globe. Next week, Saturday, 7th June at 7 p.m. Indian Standard Time, we have a discussion on bispecifics in the treatment of lymphomas from Dr. Samir Melinkari from Dinanath Mangeshkar Hospital, Pune. And the next Sunday morning, 11:30 a.m. Indian Standard Time or French time, 8 a.m., we have Dr. Harvey Tilly speaking to us. He's from France, and he'll be speaking to us on the European management guidelines as they stand in 2025 for the management of large B-cell lymphomas. As I mentioned, we have very important discussions today. Most of them are displayed here, and many of them have also expressed their desire to be discussant in last couple of days, and their names may not be here. I apologize for that, but all of them, we are looking forward to their active discussion with Satish. And now, let's have a few words about Dr. Satish. The hematology community knows him for last 20 years. One thing that I must tell you even before I introduce him, there is hardly any webinar on Saturday, Sunday where Dr. Satish Kumar has not joined either as a faculty, speaker, discussant, or audience. You have a webinar and he's there. That shows his keen interest on learning a subject which he knows so thoroughly, but wants to update and looking for that one sentence that may be picked up during the webinar. So that is a tremendous determination of this young, not so young, hematologist. So he is hematologist and hemato-oncologist at the prestigious Manipal Hospital at Yashwantpur, Bengaluru. He's consultant hematologist, hemato-oncologist, and stem cell transplant physician of, as I said, not so young, over 18 years of experience in diagnosis and management of diverse benign and malignant hematological disorders. After doing his MD in internal medicine from KMC Hospital, Manipal, he came over to Mumbai. He spent very precious couple of years doing his DM in clinical hematology at Mumbai KEM Hospital, one of the most prestigious hematology unit in the city. Not only that, he further specialized with the help of a fellowship in leukemia and stem cell transplantation from Vancouver Hospital, Canada. After he came back, he has been associated with the Manipal Hospital, formerly known as Columbia Asia Hospital, and that's a long inning from 2008. He also gives his consulting services at the Millers Road branch from 2021. As I mentioned, he is a great academician, so he's very actively involved in academic teaching. He's delivered numerous lectures and educational sessions, both in person and virtually, not only for the regional, but even the national forums. He has also obliged us in joining MHG annual and midterm conferences at multiple times as a faculty. He has several scientific publications to his credit, and the subjects, and one of them is today's topic, is the keen interest he has in chronic lymphocytic leukemia, the subject which is very close to today's talk, lymphoproliferative disorders, and multiple myeloma. The recent ISH-BT conference held at Nagpur, I heard him speaking on BTKis, and that time I decided that he was such an authoritative presentation that not only India, but the whole globe should listen to him. And after some time, today is the day when he's doing this for us. So he's speaking to us on these protein kinase inhibitors for clinical hematologists, not only first generation, not only second generation, but right up to third generation. Before he speaks to us, it's my great proud privilege to introduce our special guest of the day today, who has spared his morning to be with us. And that is another stalwart in hematology, Dr. Mukul Agarwal from AIIMS Delhi. Once again, he needs no introduction. He has been with us for years and decades. To complete the formalities, he's associate professor in the Department of Hematology at AIIMS Delhi. He has educated himself with MBBS from Maulana Azad Medical College and Hospital, Delhi, followed by MD Pediatrics from VMMC and Safdarjung Hospital, Delhi, followed by PDCC Hemato-Oncology from the prestigious SGPGI, Lucknow, and then DM in Clinical Hematology back from AIIMS Delhi. And not only that, he has gone on to obtain PG Diploma in Hospital Management from NIH-FW Delhi. His areas of interest are vast: bleeding and coagulation disorders, myeloid malignancies, myeloproliferative neoplasms, inherited hematological disorders, hematopoietic stem cell transplantation, and the most recent subject, that is AI in healthcare, as well as the subject of GVHD. His PubMed publications are 79 with H index of 11. He's an avid reviewer for numerous national and international journals. He's worked as a principal investigator and co-principal investigator on several funded and non-funded projects. Besides his academic attachment, he's also section editor for hematology in Indian Pediatrics. He's associate editor of Indian Journal of Hematology and Blood Transfusion, and hematology expert with APMU Tokyo and NDTL India. So we are really privileged to have your presence today, this morning, Dr. Mukul. And now I hand over to you to give us some words of wisdom, especially to our colleagues and students. I'll stop here and hand over to you.
Thank you, sir. Thank you, Agarwal, sir, and MHG for bestowing this honor on me. Good morning, everyone. Good morning, sir. It's been a privilege to speak with such a speaker in front of sir with so many discussing and attendance of this webinar. I shall be focusing on the residents either from internal medicine or from pediatrics, as well as those from clinical or lab hematology. They are the front runners. They are the cornerstones of patient care management across the healthcare facilities. So for the next around 2-3 minutes, I enter the Pravachan Baba mode. To be truthful, whether you are continuing in your own field or you go into any of the super specialties, there are plentiful of learning and there is too many opportunities everywhere. The advancements are going at great speed and the opportunities are rising every day. The medical profession is going to give you a very safe and a satisfying experience for the rest of your life. So continue to care, nurture, and manage your patients in the most scientific and in the most ethical manner. Like someone has said earlier, become capable, become efficient, and success will follow your path. For today, let me focus somewhat on hematology. During our residency days, for many of us, it came as a atypical CBC report or a deranged PT or APDT profile or low fibrinogen level or DIC. But it's much more than that. This is a branch where a small microscopic clue, maybe a blast, maybe a sickle cell, a mutation on the genetic aspect, a chromosomal translocation on karyotyping. This can unlock the diagnosis of the patient. This can guide you towards a further investigation. This can guide you towards a targeted therapy. Here, the science is cutting edge, and the advances which are there in targeted therapy, be it in genomics, as well as now cellular therapy, which I consider the pinnacle of immune therapy in that regard. It's how revolutionizing this is, the field is, and how we are managing these disease disorders. What you go on to see is the spectrum of disorder, spectrum of patient, right from the neonate to the most elderly or the nonagenarians. Here you can have a neonate with inherited anemia or congenital leukemia to a nonagenarian with a relapsed lymphoma or unexplained anemia. There are very few specialties which will allow you to care for a child with thalassemia, learning to live independently, or an adult who has undergone transplant for leukemia. No other field has such an intense collaboration from bench to lab, be it a hematopathology or a pathology lab, and to the bedside. The extreme satisfaction of diagnosing blood disorders under the microscope for a sick child with hemolytic anemia or an adult with promyelocytic leukemia and starting treatment on just that basis immediately is immense. That is one of the feeling which we have all shared since our residency days. And somehow that's where my hematology journey began during my pediatric residency in Delhi. So moving to SGPJ for a fellowship was a chance. I was just going for an exam with my friends, and luckily there was no other contendant for that exam at that time. And that's where I entered hematology field. Getting into AIMS after a year was a great luck, and it was a lot of hard work which went in between. The department was the prestigious Department of Hematology at AIMS New Delhi. The training was excellent, thorough, and that was a time when I made friends for life, both from the lab and the clinical fields. And that was also the time when I decided to become a teacher in the field. That dream got fulfilled in July 2017 when I joined as assistant professor in the department. Over around last 15 years, I've seen so many advancements in the field of hematology, be it diagnostics, be it therapeutics. Sometimes feel very difficult to cope up with these advancements and remember everything. But don't you think that is the beauty of the field? It offers intellectual challenges where a peripheral smear can become your diagnostic canvas and help you decide the next line of investigations. Where there are rapid scientific evolutions going on, right from transplants, advancements in transplant, to CAR-T therapy, and now gene therapy for thalassemia, hemophilia, and so many other new advancements. At one day, you will have children with inherited blood disorders, bone marrow failure syndromes, or genetic disorders where genomics have revolutionized their diagnosis and the transplant or gene therapy are moderating their cure, curing more and more patients worldwide. Then you can have adult, elderly, or really old people with myelodysplastic syndromes or plasma cell dyscrasias, cancer-associated thrombosis, CML, CLL, where precision and targeted therapies are now a everyday tool, which are utilized by hematologists and oncologists for their management. The field offers you so many things. You get to choose your own path, whether you go to an academic center or practice community hematology, whether you go on to become a researcher or totally into the private practice, whether you go into practice of benign hematology, malignant hematology, transplant, or now even CAR T specialist. The focus is to diagnose, prognosticate, and manage these sometimes very difficult patient, and not sometimes, I should say, often very difficult patient, and offer them a cure with the best modalities applied in the most scientific, cost-effective, and ethical manner. Lastly, as a teacher, I encourage you to write, publish your thesis, publish your case reports, your case series, collaborate with your colleagues for various studies, for research output, for combining data, participate in various research groups. Opportunities are plenty. Someday, you will be here speaking like me, speaking like Dr. Satish. We are all not so young hematologists in the field. 10, 15 years post your MD, you are here. So with this, I'd like to welcome you all to this challenging but immensely rewarding field. Baba phase over. Over to you, sir. Thank you.
Thank you, Mukul, for that beautifully crafted speech. Lot of words of wisdom with your last 20, 30 years of experience, and indeed grateful to you for sparing your morning. We come to the scientific subject now, and I'll be handing over to Dr. Satish, but I'll just take a minute to introduce the subject with one case. It was almost about 20, 25 years ago when I treated one not so old man with FCR for his symptomatic CLL. When he relapsed, we didn't have anything much to offer him after this treatment. Appeared on the scene the first BTK inhibitor, ibrutinib, at that moment costing 2.5 lakhs a month. This gentleman wondered, and then he reluctantly accepted the treatment because he had no option. I was myself very scared, knowing the entity Bruton's A gamma globulinemia. I was sure that this gentleman will die with this drug. It is now 12 years since that time. The man flourished. He did go on to develop Richter syndrome, and that was my first patient who underwent CAR T therapy at Israel, and once again he has been kicking. 20, 25 years of CLL. The man who was just 50-year-old is today about 75 years old. So with that background, I will hand over the platform now to Satish to discuss this wonderful journey of CLL, which is totally revolutionized in last 12 years.
Thank you so much, sir. Thank you for that introduction. I sincerely thank MHG and Dr. M.B. Agarwal, sir, for giving me this opportunity to speak on this topic. M.B. Agarwal, sir, has inspired a lot of Arjunas and Ekalavya's as a Dronacharya in hematology. Preparing for these talks makes us to delve deeper, and we ourselves keep ourselves updated. As Dr. Mukul said, if you don't update yourselves, you will be outdated. So it's a rapidly evolving field. Thanks for those kind words, sir. So with that, I would start my topic. So sir has given the perfect introduction for the topic today for BTK inhibitors from first generation to third generation. I've kept the topic a little basic. Pardon me, seniors, if you find it little basic. And also there is an explosion of clinical trials and data with BTK inhibitors in many fields. So I've tried to be little comprehensive. And again, pardon me if I go little outside the time provided. So outline, I would be speaking about BTK biology and mechanism of action to understand the inhibitors better. The three generations of BTK inhibitors we have, the pivotal clinical trials and evolving indications. This will take the most of the talk time for in CLL, mantle cell, Waldenstrom's, Margin-Zoll, CNS lymphoma, and other indications which are coming up. We need to know about the adverse effects and how to manage them, and also the mechanisms of resistance and drug sequencing. And we'll touch a bit about the newer kits on the block, the BTK degraders, which work beyond the PCR pathway. So a bit about the history. In 1952, Dr. Bruton, who worked in US at Walter Reed Army Hospital, observed small infants who had recurrent infections and didn't have any antibodies, no antibodies, A-gamma globulinemia. So at that time, they were not aware what was causing this. Almost 4 decades later, the Bruton tyrase kinase gene was identified. That was labeled, the disease was labeled as Bruton's A-gamma globulinemia. Later, it was termed as X-linked A-gamma globulinemia after knowing the mode of inheritance. So in 1993, they discovered that the gene responsible for this immunodeficiency was BTK gene. And they showed that BTK's role in early B development, it is critical for B cell development. Without it, the B cells get stuck at an immature stage. So what is BTK? BTK is a protein, signaling protein in the cytoplasm of the cell, not on the receptor. BCR is on the receptor, whereas BTK is a signaling protein in the cytoplasm. It is a tech kinase family, and we can call it as the linchpin or the engine of BCR signal transduction. I'll explain to you in detail. So what it does is, it transmits signals from the BCR receptor on the surface to the nucleus. So this is the linchpin in between, which is responsible for the B cell development, activation, and proliferation. So this slide looks a little busy, but I'll just try to explain. Whenever an antigen is bound to the B cell receptor, there is a domino effect, and it leads to a signaling cascade. Like proteins like lin and sig get phosphorylated, which then activate the BTK. BTK is like an amplifier, just like you switch on and you have a sound amplifier. So BTK in turn phosphorylates PLC gamma 2, which then the downstream pathway is activated, finally leading to activation of NF-kappa beta, NFK beta, NF80, and ERK1/2 in the nucleus, which leads to the B cells activation, proliferation. It has got many roles: adhesion, migration. And now we know that BTK is not only activated from B cell receptors, the other receptors like TLR, chemokine receptors, Fc gamma receptors, which all converge into BTK. So it has a major role in not only in B cell development, but also in activation, proliferation, migration. And this BTK, the structure is like this. It has these 4 or 5 domains: pH domain, TH domain, SH3, SH2, and catalytic domain. The important one is Y223 and Y551. This is the site when phosphorylated, it gets activated. And in turn, this is the ATP binding site, cis481, where the ATP binds and it further phosphorylates the PCL gamma 2, and the downstream cascade gets activated. We'll find out what is the importance of this soon. So once the scientists identified the importance of BTK in BCR pathway and in B cell maturation and proliferation, they started working on BTK inhibitors, and ibrutinib was the first-in-class agent, and it heralded the era of chemo-free regimen for B cell malignancies. It became so famous that the global size of the global market of ibrutinib was almost $9.44 billion in 2020, and was the 4th top-selling cancer drug worldwide in 2021. It was like a blockbuster drug. So ibrutinib was like our Maruti 800, first generation. It was good. It served its purpose, but it had a lot of safety and toxicity issues. So we then scientists developed second generation BTK, the prototype, or mainly acalabrutinib and zanubrutinib. We also have tirabrutinib, mainly in Japan, and orelabrutinib, mainly used in China. These were good, but again, there was some resistance mechanisms. It was like a cat and mouse race between scientists and the rapidly evolving malignant B cell. So then the third generation BTK inhibitors were discovered, pirtobrutinib and nemtabrutinib, which were like the recent Mahindra XCV. Amazing, safe, works even in resistant pathways, when they develop resistant pathways to first and second generation. So we have first, second, and third generation, and these are the indications where they have been approved and are being used. So this is a sort of, it traces our journey from basic science to bedside impact. So from when this gene was identified or noted to cause problems, identified in 93, to 2009, when the first BTK inhibitor was discovered, the trials were started, and 2013 was the year when ibrutinib was first actually approved for relapsed refractory mantle cell lymphoma, followed by CLL patients with deletion 17p, the high-risk group, followed by Waldenstrom's macroglobulinemia, and then all the indications in CLL, mantle cell, margin zone lymphoma, everything came in. So to discuss about BTK inhibitors, I would first discuss their indications in CLL. Again, BTK inhibitors it heralded the era of targeted therapy. This is one disease after CML which has revolutionized in the last 1 decade. So it's almost 10 to 11 years that ibrutinib was first approved, around almost in 2014 for CLL. And since then, at least in last 5 years, I think no one is giving chemotherapy in CLL. At least in US, they have stopped giving chemotherapy and they have completely switched to targeted therapy. So as I said, BTK is the linchpin in the BCR pathway. And if we block this BTK, the BCR pathway is not propagated, and it affects the cell survival and proliferation. So it blocks the BCR signals to the CLL cells, leading to the apoptosis and death of the CLL cell. Ibrutinib has been approved for newly diagnosed CLL, relapsed refractory CLL, young and elderly CLL, irrespective of the high-risk genes, whether they have unmutated IGHV, whether they have TP53 mutation, deletion 17p, any CLL, we can give ibrutinib. This was the landmark trial, RESONATE-2, which was the first trial which showed that ibrutinib had significantly improved progression-free survival, overall survival, and the response rate compared to a monoclonal antibody ofatumumab. You can see the hazard ratio was 0.22. That means 88% the risk of progression was decreased by ibrutinib. That was a RESONATE trial, in relapsed refractory patients. And this is RESONATE-2 trial where ibrutinib was compared to chlorambucil in treatment-naive or first-line newly diagnosed CLL patients. We have the 8-year follow-up data, and still the progression-free survival has not been reached. At 7 or 8 years, the progression-free survival was 59% for ibrutinib. So even at 7-8 years, half of the patients are progression-free. So such is the impact of ibrutinib. This graph shows that the patients who are taking ibrutinib and continue to be progression-free are not only leading a disease-free survival, but also almost a normal life compared to age-related matched population. This was pooled data from 3 to 4 studies, and they showed that CLL patients who are on ibrutinib and continue to be on ibrutinib, almost 80% of them were just like the general population. And then a lot of studies came in frontline where they compared ibrutinib either alone or in combination and compared them to the standard of chemotherapy. And it was shown that in these 2 studies, ECOG 1912 and FLAIR, it was superior to the standard of care than FCR. In Alliance study, it was shown to be superior to bendamustine rituximab. And in Illuminate study, it was superior to chlorambucil obinutuzumab. So name a chemoimmunotherapy, which is the standard, and ibrutinib alone or with combination with monoclonal antibody was superior. Does adding rituximab help? No. So ibrutinib rituximab, and when they compared ibrutinib to ibrutinib rituximab in Alliance study, there was no difference. So you can as well give only ibrutinib. And the beauty of this drug or the class, in fact, is the patients with both mutated and unmutated IGHV fared the same. So we all know that in mutated IGHV, the patients do better, even with FCR chemotherapy with ibrutinib. But when you compare the patients who have unmutated IGHV, they fare very badly with chemoimmunotherapy. But with ibrutinib, the progression-free survival was the same, irrespective of the IGHV mutation. What about the high-risk TP53 or chromosome 17p deletion patient CLL? These were the worst patients, and we all know that they have resistance to chemotherapy. Whichever malignancy has TP53, they don't respond well to chemotherapy or chemoimmunotherapy. And the beauty of ibrutinib, again, pooled data from almost 4 trials, it showed that the median progression-free survival was not reached. Even at 4 years, 80% of the patients were progression-free. So that's the beauty of this drug. So can we use it even in early patients like the Raj stage 1 or 0 or Binet stage A patients? So they did a study where early stage CLL patients, this is again a phase 3 study where they were randomized with newly diagnosed CLL, asymptomatic patient CLL were randomized to ibrutinib versus placebo. So it did not show any advantage in overall survival. And though there was a bit of progression-free survival advantage, there was no overall survival advantage. And so the standard still remains the same for newly diagnosed asymptomatic CLL. We should still watch and wait, only irrespective of the genetic problem, whether they have 17p, TP53 mutation, unmutated IGHV, we should still closely watch and wait. So though ibrutinib is the first in class, it's not the best in class. It did come with some baggage of adverse effects, which I'll be discussing in detail. The mechanism is explained here. So we needed safer drugs. When we saw the real world evidence, the discontinuation rates, almost 20% of the patients discontinued due to side effects. So 1 in 5 patients, this is in first line. And in relapsed patient, almost 40% of the patients discontinued due to adverse events or intolerance. So we needed safer drugs. And then we got second generation BTK inhibitors, acalabrutinib and zanubrutinib. This is the kinome map. You would have seen a lot of times. Bigger circle means non-specific, smaller circles means good. The lesser the IC50, the better it is. You can see the more potent they are. You can see that among all the other kinases, they have acalabrutinib and zanubrutinib have very high values. That means they are not specific for them. So it's only specific for BTK. The lower the value, the more potent they are for that. So we have 2 safer second generation BTK inhibitors, and in treatment naive CLL, both of them in this Elevate TN trial showed acalabrutinib with obinutuzumab and alone was superior to chlorambucil obinutuzumab. The progression-free survival was just similar to ibrutinib at almost 60 years, 80% of the patients taking the combination and almost 60% of the patients taking acalabrutinib had progression-free survival. Similarly, with zanubrutinib, compared to bendamustine rituximab, the progression-free survival at 42 months was 82% with zanubrutinib compared to 50% with bendamustine rituximab. So both of them were found to be superior to the chemoimmunotherapy, and there was lower rates of atrial fibrillation, hypertension, and bleeding, which is what we wanted. The discontinuation rates was less than 10% in both the trials. So we have 2 drugs which are better than ibrutinib. Have we compared ibrutinib to acalabrutinib and zanubrutinib and found out which is better? So we don't have data in first line, but we have 2 trials which have compared in CLL. So one is Elevate RR trial, which was again a phase 3 randomized control trial, which compared acalabrutinib to ibrutinib. These were patients, 533 patients with previously treated CLL, and including high-risk patients were assessed. And you can see that acalabrutinib was non-inferior to ibrutinib. Almost the graphs are overlapping, so it was non-inferior to ibrutinib. But the best part was the side effects. The cardiac events overall were quite less with acalabrutinib compared to ibrutinib. The time to discontinuation to adverse effects was also lesser with acalabrutinib. And except for infections, all the other side effects like atrial flutter, fibrillation, hypertension, bleeding was significantly less with acalabrutinib compared to ibrutinib. So it was a safer drug compared to ibrutinib. What about zanubrutinib? So we have this trial, Alpine trial, which compared zanubrutinib to ibrutinib. Surprisingly, zanubrutinib was not only non-inferior, but proved to be superior to ibrutinib. You can see that the 3-year progression-free survival with zanubrutinib was 65%, whereas it was 54%, statistically significant superior progression-free survival in, again, relapsed refractory CLL patients. The cumulative incidence of cardiac disorder was higher with ibrutinib, lower with zanubrutinib, and even the serious cardiac events, if you can see, it was 9.6% with ibrutinib, whereas it was 3.1% with zanubrutinib. So in adults with relapsed refractory CLL, progression-free survival was longer among patients who received zanubrutinib among those compared to those who received ibrutinib, and it was associated with fewer adverse effects. One thing to remember is all the cardiac effects or side effects are not the same. With zanubrutinib, the hypertension, the risk of hypertension was almost equal or slightly lower than ibrutinib. So I'll come to that later. Yeah, you can see here, the neutropenia, the hypertension, diarrhea, arthralgia were almost similar to ibrutinib. Then came an issue. So we had second generation inhibitors, which were more safer, equally or more potent than ibrutinib in CLL, but then we started seeing resistance issues. So BTK was very smart. It started getting mutations so that the drugs cannot bind to BTK. So almost the BTK mutations accounted to 50%, followed by PLCG2 mutations. Some of them had both of them. PLGC2 mutation is in the downstream, so none of the BTK inhibitor can act on that. But majority of the patients had BTK mutation either alone or in combination with PLCG2 mutation. So BTK inhibitors so far have led to impressive progression-free survival, overall survival in the first-line setting. It not only improved the progression-free survival compared to chemotherapy, but also had an overall survival advantage. But the issues with BTK inhibitors in CLL was they have to be used indefinitely. When they use indefinitely, the question of resistance, the problem of resistance comes in, resistance mutations comes in. The drugs are cytostatic, not cytotoxic like venetoclax. So the incidence or the rate of CR and undetected MRD was very less or very rare. And it came with a risk of cardiac events, though lesser with second generation. There was slightly, the risk was there of cardiac events with the second generation BTK inhibitors. So the scientists thought, why don't we combine the BTK inhibitors with some other drugs and make it fixed duration so that the resistance mutations don't happen and the adverse events also are very less. So we started combining BTK inhibitors with venetoclax or BTK inhibitors, venetoclax, and a monoclonal antibody. And surprisingly, there was a synergy between the BTK inhibitors and venetoclax. The ibrutinib mobilized the CLL cells out of the protective niches in the lymph nodes into the blood, and there it accelerates it sensitizes these cells to the apoptotic killing by venetoclax. So finally, they kill the resting and divided CLL population cells. So this was first demonstrated in Captivate fixed duration trial, where they gave 3 cycles of ibrutinib lead-in, followed by 12 cycles of ibrutinib venetoclax. It was the fixed duration, only 12 cycles. Till now, we are talking about indefinite treatment with BTK. This is a trial which first explored the option of 12 cycles of ibrutinib venetoclax. And it was a beauty. Almost 80% of the patients had undetectable MRD at the end of 1 year. And you can see even with patients, all treated patients, with or without deletion 17p had the same progression-free survival. And none of the patients developed BCL2 or tyrosine kinase mutations. There were some adverse effects, especially neutropenia, hypertension, infections were present. With time, now we have the 5-year follow-up data. We can see that the progression-free survival for all the patients at 54 months was 70%. The least was with deletion 17p. CLL patients, which was around 45%. So these patients who relapsed, whom the drug progressed after several years, they restarted ibrutinib either alone or in combination with venetoclax and saw that they still retained the response. Almost 85% of the patients responded again to the combination, whether you use alone or with venetoclax, again, the response was seen. So that's the beauty of fixed duration. You can always restart when they relapse. And also the fear of these mutations. In 25 patients with available samples, no mutations was detected. So this fixed duration therapy mitigates the development of resistance mechanisms when we give, compared to the continuous ibrutinib. When we give it for fixed duration, the incidence of resistance mutations is very less or almost zero. But then we are not sure whether should we give it for 1 year or should we give it longer. So this trial, FLAIR trial, they did a very interesting method of MRD-based duration of treatment. So patients who developed undetectable MRD at the 1 year with the combination of, again, ibrutinib venetoclax, they received for an additional 1 year if the patients developed undetectable MRD at the end of 2 years, they gave additional 2 years of therapy. And similarly for 3 years, up to 6 years. So maximum 6 years was given. So this was MRD-based risk-adapted therapy. And they also compared it to the standard FCR group. So you can see at 3 years, the progression-free survival, it's almost 95 to 100%. The overall survival was very impressive. Again, the toxicity, you can see because it's ibrutinib, hypertension, atrial fibrillation, because it's a combination of venetoclax, neutropenia, the complications were as expected, but beautiful progression-free survivals and overall survival. So that was with ibrutinib, venetoclax. So how about adding an obinutuzumab and seeing whether we can still further increase the undetectable MRD rates, and see why add obinutuzumab? Can we just add rituximab with venetoclax and compare to ven-obin, because rituximab is more cheaper. So the trial showed two things. Adding a monoclonal antibody increased the rates of undetectable MRD, and rituximab is inferior to obinutuzumab when given in combination with venetoclax. So this is the progression-free survival at 3 years. The triple combination fared better than the rest of the arms. But we know ibrutinib has its side effects. So do we have any data with a similar combination of acalabrutinib, venetoclax, and obinutuzumab? This is the AMPLIFY trial, phase 3 trial. Again, it is a registered trial. So hopefully in US, this combination will be FDA approved soon. So in all these fixed duration trials, now they are removing the 17p or TP53 mutated patients, because we know for this high risk patients, we have to give indefinite treatment. So in this trial, again, the combination was better. The AVO combination was better than AV, and that was better than FCR-BR. This was the progression-free survival. Overall survival, unfortunately, this was done at the COVID time when they censored the COVID deaths. Both AV and AVO had a superior overall survival compared to FCR-BR, significantly, statistically significant. AVO, the side effects, if you see, again, neutropenia, it was more with the monoclonal antibody. All the side effects were slightly higher when you add obinutuzumab. Headaches is a problem with acalabrutinib. Infusion-related reactions is a problem with obinutuzumab and rituximab. Febrile neutropenia is a problem with, especially with FCR. The incidence with AV and AVO were almost 2%. Cardiac events, this is what we're interested in. So it was very low compared to ibrutinib, hardly 1.7%. Neutropenia and infections was to the tune of 10 to 40% in this combination. AVO had slightly higher neutropenia and infections. So this was about second generation and combos with second generation BTK inhibitors. But I told you that the commonest mutation to these first and second generation is at this C481. I had shown the molecule of BTK and said that this is the site where the ATP binds, and the covalent BTK also bind at this site. So this is the covalent BTK, and this is C481 on the BTK molecule. So this is the binding site. So if this is mutated, if this 481 is mutated, then none of the covalent BTKs are bound. So now the scientists have come with a non-covalent BTKi, which does not require C481 to bind. It binds at a different site, and it inhibits the BTK irrespective of this mutation at C481. So that is the beauty of pirtobrutinib. So there is a study, open phase 1, phase 2 study. In phase 1 was a dose escalated study, and phase 2, they gave 200 milligram once daily dose. And you can see that patients who have either received BTKi or not exposed to BTKi, both of them showed response. Those patients who had not received a BTKi did better than those who had received BTKi in the past. And the beauty of this drug was the grade 3 side effects were extremely rare, even lesser than compared to second generation. The only risk was infections. So infections, and apart from infections, the bleeding risk was 0. Rash, arthralgia, hemorrhage, hypertension, atrial flutter was extremely low, even better than the second generation tyrosine kinase, brutin kinase inhibitors. And this drug worked wonders irrespective of the patients had taken BTKi, venetoclax, any molecule, any combos, the drug worked. So it showed efficacy regardless of the mutation status, regardless of the reason for the prior BTK discontinuation, and regardless of whether they're exposed to other drugs. So in December 2023, the FDA granted accelerated approval to this drug for adults with CLL who have received more than 2 lines of therapy, including a BTK inhibitor and BCL2 inhibitor. So now this is the BTKi era in CLL. We moved away from chemotherapy and we are into targeted therapy, ibrutinib, acalabrutinib, zanubrutinib, and now to pirtobrutinib. Pirtobrutinib is now being tested in the first line, and we need to see in randomized trials whether the results will be better than the second and first line BTK inhibitors. So summarizing, in CLL newly diagnosed, still asymptomatic patients, we have to watch and wait. Low risk IGHV mutated patients, we can either give acalabrutinib continuously, or when I say acalabrutinib, any BTK inhibitor continuously, because we prefer now second generation due to safety. I have mentioned acalabrutinib or venetoclax, obinutuzumab fixed duration. In unmutated patients, this is the group where adding the monoclonal antibody has shown better responses, like in the Elevate trial or in the combination trial. Adding obinutuzumab improved the PFS rates in IGHV unmutated. That is why in IGHV unmutated, they recommend adding obinutuzumab acalabrutinib, giving continuously, or you add venetoclax and give for a fixed duration. How long, whether it should be MRD directed, is still to be, the guidelines have to still come. As of now, they say if the MRD is undetectable, you can take a chance of stopping the drugs. We can also give when obin fixed duration, and when the patient relapses, again repeat it, because the patient will retain the response to this drug. But for high-risk CLL, especially when they have deletion 17p or TP53 mutation, the only drug which has to be given is BTK inhibitor, and that too indefinite. So you can see the BTK inhibitor is there in all sorts of CLL. So any patient with CLL, you are not wrong in starting BTK inhibitor blindly if he doesn't have any cardiac effects, cardiac issues. You can blindly start acalabrutinib, whether it is low risk, high risk, you'll not go wrong. So what if this patient relapse? So if you have given a covalent BTKi, you can go to non-covalent BTK like pirtobrutinib, or you can try venetoclax and obinutuzumab. And that's how we sequence CLL now. We still have a lot of drugs in the armamentarium. We have CAR T cells, we have bispecific antibodies, we have BTK degraders. So the sequencing scenario will soon change to involve all those drugs. So now that we are not using covalent BTKi indefinitely, in majority of the patients, except for 17p deletion, we can always restart the, especially if you have started acalabrutinib, venetoclax with obinutuzumab, we can always re-challenge those patients if the patient relapses after 3 to 4 years later. So we have so many options in the treatment of CLL. So that's about chronic lymphocytic leukemia. Coming to mantle cell lymphoma, which is a completely different ballgame. It's a very heterogeneous disease. We have patients with indolence disease to the most aggressive type of the disease. And unfortunately, again, like CLL, the median age of diagnosis is 65 years. They have a high risk of relapse and drug resistance is present. TP53 mutation is seen in quite a few patients with mantle cell lymphoma. So these are the three poor prognostic features: Ki67 more than 30%, TP53 deletion, and blastoid or pleomorphic morphology. The standard of care so far has always been chemoimmunotherapy, like 3 cycles of RDHAP, followed by 3 cycles of RCHOP, followed by autologous transplant. But still, the median survival is only 3 years. So we have a lot of FDA-approved therapies for mantle cell lymphoma, and along with the other drugs, BTK inhibitors have also been approved, mainly in resistant or refractory patients. Especially, they should have received at least one prior therapy. All the 4 drugs, ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib, have been approved for MCL in the relapse setting, based on these trials which I've shown here. What about the first line or treatment naive mantle cell lymphoma? Is there any data? So I'll just quickly discuss few trials which have been done in frontline or untreated mantle cell lymphoma. So this is the SHINE trial, which first shined light on the BTK inhibitors in mantle cell lymphoma. So patients were either given bendamustine rituximab, these are elderly patients, or given BR with ibrutinib. So in patients who received ibrutinib with BR, ibrutinib was continued until progressive disease or unacceptable toxicity. Rituximab maintenance was the same in both the arms. So this showed that the progression-free survival was definitely better when you combine ibrutinib with BR compared to BR, but there was no overall survival advantage. And of course, it came with its own adverse events baggage. So the FDA later removed the approval for ibrutinib in second line or in mantle cell lymphoma because of the adverse effect profile. Now we have a similar trial, the ECHO trial, which instead of ibrutinib, they replaced with acalabrutinib. So acalabrutinib, bendamustine rituximab compared to bendamustine rituximab, and we can see that there was a significant progression-free survival, and also with the COVID death censored, there was an overall survival advantage. So the combination reduced the risk of progression and death by 36% when compared to bendamustine rituximab alone. So we have elderly patients who can tolerate bendamustine. So can we just give ibrutinib rituximab? So this is the ENRICH trial where elderly patients were randomized to ibrutinib rituximab or chemo. Chemo means either bendamustine rituximab or CHOP. Almost 400 patients were randomized, 200 to chemotherapy and 200 to the ibrutinib rituximab combination. And they showed that the progression-free survival was better. It was well tolerated. Compared to the group as a whole, it was much better. But when they dissected, the progression-free survival was better to the patients who received R-CHOP. I don't have the graph, but the patients who received BR, the difference was not much and the graphs overlapped. So at least we can say that ibrutinib rituximab is non-inferior to bendamustine rituximab and quite superior to R-CHOP in this elderly set of patients who cannot tolerate chemoimmunotherapy. We have a similar trial with acalabrutinib, the Altamira trial, which is again a open phase 2 trial where they gave patients acalabrutinib with rituximab. They did not compare, it was not a randomized trial. So acalabrutinib in the previous trial, ibrutinib was given till progressive disease or death. Here acalabrutinib was given and modified according to the MRD. High-risk patients were treated indefinitely till progressive disease, but low-risk patients can discontinue acalabrutinib when they are MRD negative. Minimum treatment is 1 year. So this is the progression-free survival. The 12-month progression-free survival is 90%. 24-month progression-free survival is to the tune of 75%. And the low-risk patients did much, much better compared to the high-risk patients. And when they compared to a historical data who received mainly chemoimmunotherapy like bendamustine rituximab, the progression-free survival with acalabrutinib rituximab was slightly better. So acalabrutinib rituximab most probably will become one of the treatments for elderly patients with newly diagnosed mantle cell lymphoma. And as I said, almost 56% of the patients, especially the low-risk disease, were able to stop the treatment because they achieved MRD. At 12 months, 48% stopped, additional 8% stopped at 24 months. Almost half of the patients stopped by the end of 2 years, the drug also, because they were undetectable MRD, which was not heard of with any therapy till now with MCL, and it's just a tablet therapy. We also, just like acalabrutinib, venetoclax, obinutuzumab in CLL, this is a trial, acalabrutinib, venetoclax, rituximab in treatment-naive mantle cell lymphoma. Though the number of patients was less, 21 patients, they showed that this treatment is tolerable, and the complete remission by PET scan was almost to the tune of 90%. The 2-year progression-free survival was 95%. This is actually, if you take the COVID deaths, it was less, but if you censor the COVID deaths, it almost came to 95%. And again, it was well tolerated, mainly the usual infections, neutropenia. Only very rarely patients had hypertension, no instances of atrial fibrillation. So the authors concluded AVR is well tolerated and safe for patients with newly diagnosed mantle cell lymphoma. 100% of the patients responded, 90% achieved CR. So it led to a high rate of complete molecular response. What about zanubrutinib? So there is a study only in patients with TP53 mutated patients, which are the highest risk patients, which don't do well with chemoimmunotherapy. So this is a phase 2 trial where 25 patients of mantle cell lymphoma treatment naive with TP53 mutations were given this bovine combination, that is zanubrutinib, obinutuzumab, and venetoclax, and minimum of 24 cycles. Venetoclax and zanubrutinib were actually continued indefinitely. Only if they achieved undetectable MRD, they stopped the treatment. And you can see in this high-risk group also, the 2-year progression-free survival was 72%, overall survival was 76%, which is a big number in this subgroup of high-risk group of mantle cell lymphoma. So this is about elderly patients where we just try to prolong the progression-free survival and try to achieve undetectable MRD. But what about young patients? Young patients where we do autologous transplant, have BTK done any difference? This is one of the studies where it is a little complicated. The arm A was a standard arm where they gave 3 R-CHOP, 3 RDAP, followed by transplant and observation. Arm B, it is the same as Arm A, but whenever they gave RDAP, they gave ibrutinib also. So 3 cycles of ibrutinib RDAP along with R-CHOP, followed by autologous transplant, followed by 2 years ibrutinib maintenance. And in the last arm, they did not undergo the transplant, the same as the second arm, where they gave R-CHOP 3 cycles of ibrutinib RDAP, 2 years of maintenance, but they did not undergo transplant. And to everyone's surprise, we somehow expected adding ibrutinib to the patients who underwent transplant, the progression-free survival or failure-free survival will be better. But surprisingly, the patients, the third experimental arm patients who did not undergo the transplant also did better compared to the patients who underwent transplant, which is a standard arm. There was no comparison between the patients who underwent transplant with ibrutinib and who did not undergo transplant. The study was not powered to compare between those 2 arms. But this was the first study which showed that we may skip transplant soon in even the young patients with mantle cell lymphoma. So relapsed refractory mantle cell lymphoma, these are all the drugs, and you can show that the BTK inhibitors are slightly better than the usual lenalidomide, bortezomib, lenalidomide, rituximab. And when you combine ibrutinib with venetoclax, the response rates even further increase. So the Simpatico trial combined ibrutinib with venetoclax, and this trial is still recruiting patients where they're comparing acalabrutinib with venetoclax. In Simpatico trial, it's a phase 3 trial where they compared ibrutinib venetoclax to ibrutinib alone, and they showed that the combination had a superior outcome compared to ibrutinib. And we have even pirtobrutinib in mantle cell lymphoma also. Similar to CLL, the patients who were resistant to BTK inhibitor due to mutations responded to pirtobrutinib. So when you see the NCCN guidelines for mantle cell lymphoma, you can see all the yellow things are with BTK inhibitors, whether it is elderly patients or young patients, aggressive regimens. BTK inhibitors have come up into all lines of therapy. And now in TP53 mutated mantle cell lymphoma, they recommend using zanubrutinib, obinutuzumab, venetoclax combination after the trial, which I showed. Or if you're using transplant, you have to add BTK inhibitor, whether ibrutinib or acalabrutinib in the R-CHOP, RDAP arm before going for transplant. In patients, and they recommend to give ibrutinib or BTK maintenance for at least 2 years apart from rituximab. In second-line therapy, these drugs have already come in as the preferred regimens in patients who relapse, especially following chemoimmunotherapy. If they've already received BTK inhibitor, we can give pirtobrutinib. So this is about mantle cell lymphoma. The next group is a rare disease, Waldenstrom's microglobulinemia, but very interesting disease. It's an indolent B-cell lymphoma compared to mantle cell. It's quite indolent. Infiltration by lymphoplasmacytoid cells characterized by IgM monoclonal gammopathy. It is indolent, incurable, and the median survival is 10 to 12 years. Just like in any CLL patient, we check for TP53 mutation, 17p deletion, and IGHV mutation status. In Waldenstrom's, for any patient with Waldenstrom's patient, we have to check for these 3 mutations: MYD88 mutations, CXCR mutations, and TP53 mutations. MYD88 mutations are seen in almost 95% of patients with Waldenstrom's macroglobulinemia. NGS misses them, so you need to talk to the lab and tell them to do by allele-specific PCR. CXCR can be done by NGS or PCR, which are present in 30 to 40%. There are 2 types of mutations, nonsense and frame shift mutations. TP53 mutations, in just like CLL in newly diagnosed, only 10% have, but relapse refractory, almost 25 to 30% of the patients have these mutations. Why is it necessary to do these mutations? Because in patients who have MYD88 mutation alone, they respond very well with rituximab, with BTK inhibitor. Sorry, they respond very well with BTK inhibitor. So this is the CXCR wild type. So MYD88 mutated, but CXCR wild type, they respond very well. If they have MYD88 and also CXCR mutation, they don't do as well as they do with the first group. So the response rates are anywhere between 60 to 80%, especially if they have the nonsense mutations with CXCR4, the response rates are very less. And the other group, that less than 10% group where the MYD88 is wild type, they don't respond at all to ibrutinib. So without checking, you cannot blindly start a BTK inhibitor. You will be wrong in starting BTK inhibitors, especially if they do not have the MYD88 mutation. And even if they have the mutation, if they are CXCR mutated, the response rates is less. So we need to know about the mutation status before starting treatment. We all know about overall response rate, but in Waldenstrom's, we talk about major response rate. Major response rate involves the addition of complete response, very good partial response, and partial response. So this is the trial which led to the approval for ibrutinib monotherapy in patients, relapsed refractory patients with Waldenstrom's, where the major response rates, as you can see, in the first subgroup where MYD is mutated and CXCR is wild type, is up to 97%. Both of them mutated 68%, and none of the patients with MYD without mutation responded to ibrutinib. The same thing is depicted here. You can see the fall of serum IgM. They respond beautifully very soon, and the hemoglobin improvement in all the three subsets. Combining rituximab with ibrutinib was slightly, definitely better to rituximab alone, but it came at a cost of toxicity. This is a phase 3 innovate study where the combined ibrutinib was given continuously till progression, whereas rituximab was limited number of cycles, and ibrutinib rituximab, as expected, was quite superior to rituximab alone. The problem with this ibrutinib rituximab was the risk of the grade 3, grade 4 side effects. So you can see the atrial fibrillation, 16%, infection risk was high, the hypertension risk, neutropenia, all these were high in the combination arm. So do we have data for a second line of BTK inhibitor in Waldenstrom's? So this is the landmark Aspen trial where they compared both treatment naive and relapsed patients with Waldenstrom's macroglobulinemia. The randomized in the cohort 1, the randomized between zanubrutinib and ibrutinib as a single drug only, and they were risk stratified by CXCR status. In the cohort 2, the wild patients, which we know that ibrutinib has zero response, MYD88 wild type, were given zanubrutinib alone. And look at the responses. So if you look at here, the major response rate, you will feel that the response rates are almost the same, like 81.4%. This I'm talking about the mainly the overall survival. But time to response is very fast with zanubrutinib compared to ibrutinib. Within 7 months, the patients achieved complete response or VGPR. When you go to the subgroup of CXCR mutated patients, where we know ibrutinib, the chances are less, the zanubrutinib has a better role. Almost 80% of the patients responded compared to 65% of the patients. And again, the time to response was faster with zanubrutinib compared to ibrutinib. And the last cohort, which is MYD88 wild type patients, where the ibrutinib showed zero response, almost 65% of the patients showed response within 7 months, even in this subgroup. So zanubrutinib is definitely a better drug compared to ibrutinib. And as expected, the side effects, even at 36 months, the rates of atrial fibrillation, hypertension, diarrhea, bleeding were all less compared to ibrutinib. The risk of neutropenia and infections were almost much same. Just like CLL, mantle cell lymphoma, pertubrutinib also helps relapsed patients who have developed mutation in the CYS481 on routine tyrosine kinase. So this is like a phase 1, phase 2 study where they showed that patients who have been exposed to a covalent BTKi, almost 66% of the patients responded to the pertubrutinib. So even in this subgroup, the major response rates were very good when they get exposed to pertubrutinib. So how do we use genomics and BTK inhibitors in Waldenstrom's? So you need to check for these mutations. If the patient has MYD mutated and CXCR wild type, BTK inhibitors is the best drug. If they have both MYD and CXCR mutations, actually these patients are very aggressive disease. Most of the times they have symptoms of hyperviscosity. They may need plasmapheresis. Better is to do bendamustine rituximab in these aggressive patients where we need to decrease the IgM level faster. If rapid response is not required, zanubrutinib is a better drug to give in these patients. And when they're wild for both, which is a less than 10% subset, zanubrutinib is the drug of choice. In relapsed patients, depending on what you give, you can change the BTK inhibitor or use bendamustine rituximab, or we can use non-covalent BTK inhibitors. These are some of the guidelines. So suppose you need deep IgM response, use zanubrutinib. In Bing-Neal syndrome, where there is a CNS involvement by Waldenström, use ibrutinib or tirabrutinib, which have better CNS penetration. If there is a predisposition to arrhythmia or bleeding, use zanubrutinib. If they have neutropenia or pancytopenia, prefer ibrutinib. And these things I discussed. If they have a TP53 mutation, use zanubrutinib. And if they're intolerant to ibrutinib, you can always use zanubrutinib. If they have resistance to covalent BTK, you can use a non-covalent BTK inhibitors. So that's why genomics, disease characteristics, and comorbidities have to be considered in positioning the BTK inhibitors in both treatment-naive and previously diagnosed, previously treated Waldenstrom's microglioma patients. There's one more peculiar thing they observed in patients with Waldenstrom microglobulin. Whenever they're stopping ibrutinib for, say, some procedure, we stop it 5 to 7 days, they used to develop withdrawal symptoms in 20% of the patients. They developed fever, headache, night sweats, arthralgias, chills, headaches, fatigue. Within the 2 days of holding ibrutinib, they used to develop these patients. And once we restart the therapy, the symptoms used to resolve. This is because of a serum IgM rebound, which can happen when ibrutinib is withheld. So the authors suggest whenever we withheld and they develop, because it happens in 20% of the patients, start steroids until you hold the BTK inhibitor. Once you restart the BTK, we can stop the steroids. Margin zone lymphoma, I'll quickly rush through. So in relapsed refractory margin zone lymphoma, ibrutinib has shown responses. The overall response rate is to the tune of 58%, and duration of response was 27.6%. So when they saw into the biomarkers, patients who had mutations in MYD88 and 820, they had improved outcomes compared to the mutations in KMT2D and CARD11. If you remember our first slide, CARD11 comes downstream in the downstream pathway to BTK. That's why when these mutations are there, they don't respond to BTK inhibitors. This comes downstream in the signaling cascade to BTK. Similarly, with acalabrutinib, 40 patients, relapsed patients, overall response rate 52%, 12-month progression-free survival 67%, the tumor shrinked 93%. Majority of the patients with acalabrutinib, the side effects are neutropenia, anemia, no AF, no major bleeding, only 7% discontinued. So it showed a promising efficacy and tolerability in relapsed marginal zone lymphoma patients. The same thing with zanubrutinib, irrespective of nodal, splenical, marginal zone lymphoma, the overall response rates was to the tune of 60 to 70%. Again, it had a favorable safety profile. So if you look at marginal zone lymphoma, in the second line therapy, the BTKs have been recommended and they have been approved and they're recommended by NCCN guidelines. So the preferred are acalabrutinib, zanubrutinib, and if they have received earlier a covalent BTK, to use pirtobrutinib. What are the other indications apart from these four, CLL, MCL, Waldenstrom's, and marginal zone lymphoma? Have they looked into other indications? One interesting thing is primary CNS lymphoma. Majority of the primary CNS lymphoma are ABC type, the activated B cell type, DLBCL, and they have high rates of this MYD88 mutation and CD17 mutations with constitutive NFK beta activation. These are the group of patients where BTK inhibitors have a significant role in helping the patients. So this drug was licensed in Japan to manage relapsed refractory primary CNS lymphoma. The BTK inhibitor is called as tirabrutinib. This is one picture which showed the response rate, the baseline, the tumor is this. By the end of 14 months or 10 months, the patient developed complete response. In a trial, the overall response rate was 63%. Only single drug tirabrutinib, and progression-free survival was 2.9 months. So these are all the trials which are going on with relapsed refractory CNS lymphoma. As single drugs, they didn't do great, but in combination with chemotherapy, the patients are responding better. This is the CSF to total plasma concentration ratio. Ibrutinib, tirabrutinib, zanubrutinib have reasonable levels in the CSF compared to other BTK inhibitors. That is why these drugs are being studied in both the relapsed refractory, and also they're studying in the treatment-naive primary CNS lymphoma. We need to wait for the reports. As of now, only tirabrutinib is approved in Japan. The other drugs are not approved. One of the studies which I came across was very interesting, that if you combine BTK inhibitors with CAR T cell therapy, also the response rates were better. How does BTK inhibitor help with CAR T? They reduce the T cell exhaustion markers PD1 and TIM3 and enhance the T cell function. So both in Transcend CLL trial and Tarmac trial, they've shown very high overall response rates and complete response rates when they use BTK inhibitors. Just to give an analogy, it is like CAR T cells are like soldiers who are going into the battlefield, but because of the tumor microenvironment, it is very dark there and there are many traps there. So the BTK inhibitors help in removing these traps and controlling these T cell exhaustion markers. They remove these PD1, TIM3 and make sure the CAR T cells are more effective. So when should we give it? We can either give it before leukapheresis, we can give it between leukapheresis and lymphodepletion, and also after giving CAR T cells, it has shown that it helps in during all the 3 phases of CAR T cell therapy. Is it only in CLL? So this BTK inhibitor can help even in patients with diffuse large B-cell lymphoma. So it is not like the BTK inhibitors are acting on the malignant cells. The mechanism is absolutely different. As I said, it controls these the markers which exhaust the T cells. So even in patients with DLBCL, here it was a randomized trial where they gave CAR T cell alone or in combination with BTK, and you can see that the complete response rates were 61% when they gave BTK inhibitors along with CAR T cells compared to CAR T cells alone. So there was a significant difference. So the combination of BTK and CAR19 induced good efficacy in terms of response depth and long-term survival. Prolonging the duration of BTK maintenance might contribute to superior outcome in patients with B-cell lymphoma through improving immune function. So they're looking at how long to give BTK inhibitors post-CAR T cell therapy. These are only a couple of trials I came across, very interesting. They have a role in chronic GVHD also, because we know that ibrutinib silences the BTK pathway in the overreactive B cells and the ITK pathway in T cells. They thought, why don't we try this in chronic GVHD? So this was a trial, ibrutinib plus steroids, ibrutinib with steroids versus placebo and steroids. There was no significant progression-free survival or overall response benefit, but steroid sparing effects were observed, and ibrutinib is now FDA approved for steroid refractory graft versus host disease. After this trial showed overall response rate of 67%. Other BTK inhibitors are also under investigation in GVHD, aiming for better safety and selective profiles. Beyond this, they are being explored in multiple B-cell malignancies, DLBCL, Richter's transformation, follicular lymphoma, hairy cell leukemia, primary effusion lymphoma, multiple myeloma subsets. They are seeing which is a subset of patients which the BTK inhibitors help. For example, in DLBCL in Phoenix trial, addition of BTK inhibitor didn't show any benefit, but there are some subgroups of ABC type of DLBCL which did benefit. So they're looking into further trials. They're also being tried in diseases like multiple sclerosis, Alzheimer's disease, in diseases like even autoimmune diseases, because the overreactive B cells are silenced by BTKs in autoimmune diseases like ITP, rheumatoid arthritis, MS, SLE, pemphigus. So the future is very bright for BTK inhibitors. Having said that, though there are game changers, we need to remember the adverse effects of BTK and know how to manage the toxicity. The main concern with BTK was cardiovascular side effects, because these BTKs not only inhibit the BTK enzyme, but also act wherever that CYS481 molecule is there, like other TEC kinases, EGFR, BMX kinases, and cause all these adverse events. As I told you earlier, we cannot give it as a single bracket and say that all of these are better with second generation. When you see the trials, you can see that arrhythmia's risk is much better with acalabrutinib and zanubrutinib, pertubrutinib compared to ibrutinib. When you see the hypertension rates, it is 9 to 23% with ibrutinib. With acalabrutinib, it is 9.4%, and with zanubrutinib, it's almost to the same tune as ibrutinib, 10 to 23%. So for patients with hypertension, prefer acalabrutinib to ibrutinib and zanubrutinib. The bleeding risk was slightly lesser with second and third generation BTK inhibitors. So whenever we start a patient with BTK inhibitors, there are 3 things: pre-treatment evaluation, management during treatment, and post-cardiovascular events management. In pre-treatment evaluation, we need to assess the patient, what are the cardiovascular disease he has, what are the risk factors he has, so that we have to remove the patients who have strict contraindications for BTK inhibitors, which is any history of ventricular arrhythmia, unmanageable atrial fibrillation, uncontrolled hypertension, severe congestive heart failure, recent occurrence of acute coronary syndrome, personal history or family history of sudden cardiac death. These patients are strict contraindication for BTK inhibitors. Baseline, we need to measure the BP, check the heart rate, and record an ECG. And for high-risk patients, do a 2D echo. So this again, without any cardiovascular risk factors, you can start any approved BTK. For patients with atrial fibrillation or controlled hypertension, or in past MI is there, prefer second generation BTKs. But in patients with ventricular arrhythmia, sudden cardiac death, severe congestive heart failure, uncontrolled hypertension, do not use BTK inhibitors. So this is before starting treatment. Once we start the treatment, it is advised to regularly monitor the BP, especially because the hypertension is more in the first 6 months. every time they come to the clinic, better to measure, or even if they can do ambulatory or home BP measurements, it is better to measure the BP to make sure we pick up hypertension early and control it so that it doesn't lead to other adverse effects. Get an ECG done. If not an ECG, at least ask for history of arrhythmia-related symptoms, any palpitations, breathlessness, undue fatigue, all those things, weight gain to rule out CCF. If these patients are there, they need to get a 2D echo ECG. So these are the guidelines mentioned in Journal of American Cardiology. ECG every 3 months, look for arrhythmias. And if they have some symptoms, if the ECG is normal, do a Holter so that we can pick up the arrhythmias faster and stop the drug. So in patients who develop hypertension, you continue the BTK and try to control the hypertension actively. If the optimal control of hypertension is not achieved, discontinue the BTK inhibitor. Atrial fibrillation, structured assessment of TBIP. TBIP means thromboembolic risk, bleeding risk, interactions, and patient preference. All these things have to be taken in care to decide which anticoagulation to be given. We prefer DOACs. Warfarin is contraindicated. Either DOACs or low molecular heparin can be given. Beta blockers are recommended for ventricular rate control. If the patient develops atrial fibrillation with the first generation, better to shift to second generation if you want to restart the if you want to start the BTKi once you control the atrial fibrillation. If the patient develops heart failure, it's better to discontinue BTKi immediately and don't start it again. Also, remember, I'll talk about the drug interactions, but avoid CYP inhibitors and PGP substrates as much as possible because they have an interaction with BTK inhibitors. Again, these are the guidelines, especially with atrial fibrillation. If they have CHAD score 0 or 1, continue the BTK inhibitor. But if the CHAD score is more than 1, anticoagulant with DOAC and hold the BTK inhibitor. Once the rate is controlled, use newer BTK inhibitor or reduce the dose of BTK inhibitor. Similarly, with ventricular arrhythmias and heart failure, it is better to withhold the BTK inhibitor and switch to other drugs like BCL2 inhibitors. Bleeding, again, this is the mechanism why we see bleeding in patients with BTK inhibitor, dual inhibition of BTK and TEC kinases by ibrutinib. So basically, when they studied, the aggregation with collagen is inhibited by BTK. So if you want to study a patient on BTK inhibitor, just like we use ADP, epinephrine, we can study the collagen-induced platelet aggregation, and that is impaired with BTK inhibitors. Also, there is reduced expression of other glycoproteins on the platelets. The bleeding episodes are most likely to occur within the first 3 to 6 months. The risk is higher with ibrutinib compared to second generation BTK inhibitors. So if the patients on BTK require antiplatelets or anticoagulants, as much as possible, avoid adding antiplatelets, especially avoid NSAIDs, fish oils, vitamin E, etc., which can increase the risk of bleeding. If it is mild cardiovascular risk, talk to the cardiologist and discontinue aspirin. If they have to take it for like high-risk patients, you can give single antiplatelet agent with BTK inhibitor. Avoid the combination of warfarin in patients who give anticoagulants, like say atrial fibrillation patients. Prefer NOAC or low molecular heparin. Combination of any 3 drugs which can enhance the bleeding is not recommended. Like the patients who have undergone angioplasty, if they want to start dual antiplatelets, it is not recommended. Or BTK, one antiplatelet anticoagulant is not recommended because this increases the risk of bleeding significantly. Whenever the patients on BTK have to undergo a procedure, stop the BTK inhibitor 3 days before and after any minor surgery. If it's a major surgery, 7 days before and after. These are the guidelines recommended for BTK inhibitors to avoid bleeding. Hematological toxicity, neutropenia, anemia, thrombocytopenia. We can use growth factors. We can use TPO receptor agonist. We can use erythropoietin. If they occur recurrently, we have to reduce the dose. If it occurs more than 3 to 4 times, better to discontinue the drug and use other drugs. Lymphocytosis, as we all know in CLL, in the first initial few weeks, we see the lymphocyte counts goes on increasing, typically resolves within 2 months. Sometimes they can stay for almost 6 months. There's nothing to worry. As long as the disease is not progressing, the lymph node swelling are coming down, we need not worry. BTK inhibitors are associated with infections because, again, it inhibits ITK present on them and inhibits the macrophage function. So it does affect some kinases on immune cells too. So the patients are prone to pneumonias, pneumocystis jirovecii infection, viral infections, fungal infections. But there are no standard guidelines or recommendations for antimicrobial prophylaxis. All the authors or all the articles say that in patients who are heavily pretreated, you have to individualize and start these prophylactic drugs like antibiotics or antifungals, we need to use our wisdom and start whenever we start BTK inhibitors in these elderly patients or heavily pretreated patients. Only in those patients they recommend prophylaxis. Rash most of the times is self-subsiding. Steroid creams will help. Only if they have Steven-Johnson syndrome, better to withhold it permanently. Headache is much more often seen with acalabrutinib. It can be sometimes very irritating. Usually goes away with caffeine or acetaminophen. If the platelet count is good, you can even give NSAIDs. Arthralgia is seen with all the three drugs, though lesser with second generation. Again, you can manage with NSAIDs. Just like with cyclosporin, we can give calcium and magnesium supplements if they have muscle cramps. If the patient developed arm skin thickening or lymphedema, better to discontinue the BTK inhibitor. So there was some trials where they saw when patients developed adverse effects of first generation, when we switch over to second generation, what happens? So in this trial, 33 patients intolerant to ibrutinib, not resistant, intolerant to ibrutinib because of adverse events, were switched to acalabrutinib. And you can see that almost 72% patients, there was no recurrence of the adverse event. Again, a similar study in CLL, 40% of the patients did not develop the recurrence, and other 44% recurred at a lower grade. Here, the patients who were intolerant to both ibrutinib and acalabrutinib were switched to zanubrutinib, and only 6%, 23% with ibrutinib, 6% with acalabrutinib recurred at a lower grade with no recurrence of significant side effect with zanubrutinib. So zanubrutinib was much more well tolerated than acalabrutinib when patients were intolerant to ibrutinib. What about the impact of adherence? This has to be emphasized when the patients take continuous BTK inhibitor. They have seen that missing continuous 8 days of ibrutinib led to shorter median progression-free survival in RESONATE-1 study, and also in single-center experience where the dose was interrupted for more than 1 week of ibrutinib, the progression-free survival was worse. So especially when the non-adherence occurs early, within first 8 weeks of starting the treatment. So we have to tell them to be as compliant as possible with the treatment. So this is the table of drug-to-drug interactions. You can get it easily on the net. We need to be careful because the drugs are metabolized by CYP in the liver. We should avoid strong CYP inhibitors or inducers. And if we have to use them, we should know how much drug to be adjusted based on the guidelines. Coming to the last part of the talk, which is on resistance. So the BTK, the malignant cells are very smart, and they develop various mutations in the BTK downstream pathway or other chromosomal abnormalities, metabolic reprogramming, or the tumor microenvironment itself changes so that they get resistance to BTK inhibitors. But when they analyzed 60%, when patients who take BTK inhibitors indefinitely, especially like ibrutinib, almost 60% of the patients acquire resistance due to BTK mutations. Among the mutations, BTK mutations are the commonest one, almost 50%, followed by 10% PLGC2 mutations. 20 to 30% have both of these mutations, and 20% have other mutations, which we will discuss. So when there is a mutation in C481, which is the binding site for all these covalent BTK inhibitors, none of this can help. The only drug which can help is non-covalent BTK inhibitor, which is pirtobrutinib and nemtabrutinib, which I had shown before, because they act through, they do not bind at C481, they have a different binding mechanism. So there are two types. There are not just C481 mutation. If you see, there are multiple other mutations, just like for imatinib and tyrosine kinases in CML. There are a lot of mutations which have come up. So, we can divide these mutations into two types. One is kinase active mutations, kinase dead mutations. So just in this picture, we can see that when the BTK inhibitor inhibits BTK, the cascade, the downstream pathway is not activated. In kinase proficient or kinase active BTK mutation resistance, what happens is the BTK inhibitor is present, but the BTK is active, just like the standard C481. Though the inhibitor is there, the BTK is active, and it phosphorylates the downstream pathway, and the BTK pathway is active. Here, basically, you need to choose the right inhibitor. Here, these mutations destroy the BTK activity themselves, and BTK is not active, but it acts as a scaffold for other proteins like HCK, which does the same action as BTK, and that will activate the pathway further. So in these BTK dead or BTK dead mutations, none of these covalent or non-covalent inhibitors work in these patients where there is kinase dead mutations. So finally, once the more and more BTK inhibitors are discovered, we have to look at the mutational data, which will guide us which BTK inhibitor will help, just like we do for imatinib and other tyrosine kinase inhibitors in CML. So how do we approach this BTK inhibitor resistance? One is simple, is to prevent the BTK resistance, first of all, by giving combined therapy like fixed duration BTK inhibitor with other immunotherapy or target therapy, just like in CLL we are doing, so that we do not get the resistant mutations at all. If they have C481 mutation, we can add third generation reversible BTKis, which are non-covalent like pertubrutinib and nemtabrutinib. Or if they have like something like kinase dead mutations, then we have to switch therapy to other drugs like BCL2 inhibitors, PI3K inhibitors, and there are a lot of other inhibitors which are in the pipeline. Or finally, go look at autologous transplant and cellular therapy, which can save the patient. But now we have one more drug which can almost be called as fourth generation BTK inhibitor, which are called as BTK degraders or PROTAC degraders, which are very interesting drugs. This drug has three proteins. One is the protein of interest binding domain. It has a linker and E3 ligase binding domain. What this drug does is, so this is this protein of interest binding means this part links to the BTK. This is the Bruton tyrosine kinase protein. So this binds to the BTK, and the E3 ligase binds to the E3 ligase. So the E3 ligase has ubiquitin, which when BTK is brought in proximity to the E3 ligase, it starts ubiquitinating the BTK. So it transfers the ubiquitin onto the BTK. And finally, this linker drug dissociates itself from the complex, and the BTK, which is bound to the ubiquitin is degraded by the proteasome. So wonderful mechanism of action where any drug you can decide, any protein you can decide, and you can prepare the drug in such a way that it binds to this domain, ubiquitin is added, and that is degraded by the proteasome. So the advantages are the protein is eliminated, so there is no question of other resistance to BTK, target undruggable targets, lower toxicity, lower dose, higher selectivity. However, there are some challenges. Poor cellular permeability when you give these drugs, oral bioavailability is very poor, constrained selection of druggable E3 ligase toolbox, unpredictable side effects and off-target toxicity, complexity for the chemical synthesis of this PROTAC, and monitoring off-target effect in preclinical toxicity screening is challenging. There are trials going on with PROTAC inhibitors in CLL, especially relapsed refractory patients. We need to wait, but very interesting mechanism of action. So I am coming to the end. So BTK inhibitors today and tomorrow, BTK inhibitors have definitely revolutionized the treatment of CLL, mantle cell lymphoma, Waldenstrom's, and beyond. Drug selection should be individualized. Disease biology, comorbidities, resistant profile should be taken into account before choosing which drug to be given to which patient. Future lies in next generation BTK combinations and personalized sequence strategies. From covalent blockade to protein degradation, BTK inhibition remains a dynamic frontier in precision hematology. Just like the example Agarwal sir said, there are so many patients where we thought the road has come to an end, and BTK inhibitors have come to help and have significantly affected the survival of these patients. Thank you so much. Thank you, sir.
Thank you, dear, for that complete review of the subject. We'll have some interactive session now with questions. One in the chat box is, with the presence of BTK inhibitors, are the indications for starting the treatment for CLL have changed? Will you treat asymptomatic patients and patients without cytopenia?
No, sir. So as I showed, there was a trial which they compared where the study, it was a phase 3 randomized trial where they gave for these early asymptomatic CLL patients ibrutinib and saw whether it made a difference in overall survival, and there was no difference in the overall survival. So at present, it is not recommended to start ibrutinib for early stage asymptomatic patients. Still, the RAI, BINET, and the usual indications for starting treatment remain the same, irrespective of the genetic profile.
Right. Satish, you can stop sharing so people can see you.
Oh, sorry.
Yeah, no. Yeah. Mallikarjun, your question.
So first of all, thank you for the opportunity. At the outset, I would like to congratulate Dr. Satish for a wonderful presentation, real comprehensive review. I'm sure he's put in a lot of work and he's covered every bit of it, and such clarity and thought. So thank you so much and congratulations, Dr. Satish. So my question is two-part. Number one, in CLL patients, our current conversation is around whether finite therapy with obinutuzumab venetoclax versus infinite therapy with BTK inhibitors. in your clinical trial, are you using BTK inhibitors as finite therapy in treatment-naive CLL patients, and your thought process on using them in combination with other drugs moving forward?
Right, Malik. Thank you so much for those kind words. So in CLL, if they have 17p deletion or 253 mutation, you have to use indefinitely. In that subgroup, it is very, very clear. You have to use BTK inhibitor as a single agent. There is no advantage of adding any venetoclax or obinutuzumab along with BTK inhibitor in this subset of patients of high risk CLL patients with T53 and deletion 17p chromosome patients. In the other patients, if you have unmutated IGHV, which are the worst group, there you have a choice between adding acalabrutinib with obinutuzumab and giving it indefinitely, or giving a fixed duration therapy with acalabrutinib, obinutuzumab, and venetoclax. In practice, what I do, as of now, until this amplified results came, we were giving, if I started BTK inhibitor, I'm giving still indefinitely. I'm not adding obinutuzumab because of the expenses involved and the infusion reactions, all those things. We are giving acalabrutinib indefinitely even for these patients. But I do counsel about venetoclax and obinutuzumab combination in such patients. In mutated patients, whatever you do, you're right, because there's a good subset. I mean, even if the patients can't afford, you can even give bendamustine rituximab, though it has gone out of practice. Even there, you're not wrong in giving either any of the choices. Only in unmutated, we're a little stuck. Should we give AVO or venetoclax ibrutinib fixed? And if so, when to stop it? Should MRD guide us? So this is the catch in unmutated IGHV CLL patients.
Thank you. So in an ideal world, what thought process would you use to go for obinutuzumab venetoclax as against BTK inhibitor apart from 17p deletion? What are the patients?
So I think with the results coming up, we have to, there was no combination of acalabrutinib venetoclax without obinutuzumab and give it for a fixed duration, either ibrutinib venetoclax or acalabrutinib venetoclax. At the end of 1 year, do the MRD. Recently, sir had invited Dr. Nitin Jain. So we were discussing the same thing with him. He said, we should start doing MRD for these patients. And if there is undetectable MRD at the end of 1 year, we can safely stop it so that the resistance does not set in, Malik. So the combination of BCL-2 inhibitor and BTK inhibitor will be the future, and fixed duration will be the future. Because a lot of patients, when we say acalabrutinib, initially they will agree for indefinite treatment. After some months, some years, they do come and ask, can we stop it? Can we stop it? It's very difficult at that time. And we know that BTK inhibitors alone, the rate of undetectable MRD is extremely less than 5%. So it's better to give BCL-2 inhibitor along with BTK, try to get them to undetectable MRD, stop the drug, monitor them closely. If the disease relapses after several years, you can again start the same combination. By that time, I'm sure some company will come up with mutation profile, just like when we start the second generation tyrosine kinase in CML, we can look for mutations. Most of the times, they don't have any mutations when we give for fixed duration. You can restart the same combination, Malik.
Thank you. Digressing from the topic, in follicular, we have a follicular person who's exhausted everything apart from BiTEs and CAR-T. Any data that you reviewed?
We can definitely try with Acala and Zano, but they've been given at single agents, and there is some response rates in follicular lymphoma refractory to all the therapies, Malik. We can try it if you have exhausted everything. You can always try acalabrutinib as a single agent and see. I'm sure they've received monoclonal antibodies so far.
Thank you so much, Dr. Satish. Thank you so much, sir.
Thank you. Dr. Krishna Ratnam.
Thanks, Satish. You have exhausted so much, so well. Very difficult to find questions. But practically, many patients, they have some ischemic heart disease. They have had CABG. They had pacemakers. So a little bit discomfort in starting BTK. Is it okay? I mean, from what I gather, unless they have a cardiac failure, I mean, you can start. So I just wanted to reiterate it from you. And also, if somebody has got a controlled atrial fibrillation, can you go ahead and start, or you suggest a second generation?
Yes, sir. So for the second question, definitely I would prefer a second generation BTK inhibitor like acalabrutinib, which is easily available. Generics are available for these patients who have controlled atrial fibrillation. The first question, yes, sir, we do feel uncomfortable starting BTK inhibitors, especially if they've had a CABG or an angioplasty some years back. But it is very safe to start a second generation BTK inhibitor if they do not have active cardiac failure, if there is no risk of ventricular arrhythmias, if they have atrial fibrillation, the rate is well controlled, you can safely start second generation BTK inhibitor. Because these are the patients who are elderly, and if they have a high creatinine, starting venetoclax also would be a major challenge for these patients, and we don't have much of options. So case to case, we can definitely start BTK inhibitors in patients who have had cardiovascular issues, sir.
But you still prefer a second generation or?
Absolutely, absolutely second generation. In anyone with any cardiovascular disability or at risk of cardiovascular disability, suppose if their cholesterol is very high, they have diabetes, I would definitely prefer second generation BTK inhibitor for several reasons, sir. Not only atrial fibrillation, but other side effects are also quite less with second generation. And they're much more affordable now. So I think acalabrutinib would be my drug to go, sir.
And also by default, we start second generation because now the ibrutinib, we don't have generics. I think
Yes,
only
sir.
the innovator is there, and many patients they find it difficult to afford that. So it's easier to give the second generation rather than the first generation. If someone has a valvular AF and he's on warfarin, what do you do then?
That's a very challenging situation, sir. I think I would not give BTK inhibitor because they suggest not to give BTK inhibitor with warfarin at all. So we have to look at other venetoclax-based therapies or chemoimmunotherapy if it is mutated CLL, other drugs, other options. As of now, with warfarin, they suggest not to give BTK inhibitor.
Okay, thank you, thank you.
I have one comment here.
Yes,
If you have a newly diagnosed patient who requires treatment, probably no patient should receive ibrutinib.
Agreed.
There is very little justification today. If your patient is already on ibrutinib, yes, I'm not saying that you change it to acala, but why should you ever start a newly diagnosed patient on ibru is very difficult to justify.
Absolutely, sir.
It should be at least acala, and if Zen becomes generic or the cost is affordable, it should be probably Zen, which is even less toxic.
Agree, sir.
Okay, so no more raise. No, Amit has got a question.
Thank you, Dr. Satish. Wonderful lecture, a
Thank you.
fantastic lecture. If the patient is on acalabrutinib and the patient has just developed recent MI, underwent angioplasty, now this patient is on acala plus patient cardiologist is advised to go for DAPT. So what would you do in these patients basically? Because recent MI, angioplasty done, DAPT is advisable, and we cannot go for single agent platelet therapy.
Yeah, Amit, again, difficult situation, Amit. There is no particular guidelines for this patient, but what I could gather, what I read through, you can cut down the acalabrutinib dose from 100 mg BD to 100 mg OD, especially if they are, like, say, several years into the treatment and the disease under control. You can cut down the dose of acalabrutinib to 100 mg OD.
And second thing regarding the same from the same note, basically the patient requires both antiplatelet plus anticoagulant. For
Again,
example, venous thrombosis. What would you do in such patients?
so that's what, again, triple therapy is not advocated. So if the patient requires an anticoagulant and an antiplatelet, the risk of bleeding is very high. If they're well into the treatment and they're in sort of good remission, I think we have to cut down the dose. Whether it is ibrutinib, acalabrutinib, or zanubrutinib, we have to cut down the dose if we have to use the BTK inhibitor along with that. So rather than stopping it, I would suggest to cut down the dose. Usually, like this dual antiplatelet and all, the cardiologist recommends for 6 months. After 6 months, they cut down to one antiplatelet drug. So till then, use once daily, 100 mg once daily dose rather than 100 mg BD dose. And then once the crisis period is over, you talk to them, cut down one drug, and go back to the treatment with this thing. Yeah.
Thank you.
Thanks, Amit.
Again, I have two comments. One, what stops you from changing to venetoclax-based treatment? And the second, why not take these drugs as one of the antiplatelet agents? Explain to the cardiologist, and then they are giving two. If they add one more antiplatelet agent, you've got two antiplatelet agents.
Yes, sir. That's a very interesting hypothesis, sir. Unfortunately,
I'm doing that in practice.
okay.
I don't allow them to give two antiplatelet. I say I'm already giving one antiplatelet. You just add one more. So you
Yes,
got two antiplatelet agents.
I think that's the guideline. They say give only anti-1 platelet agent. I think we just need to talk to the cardiologist. So regarding the first thing, whether we can switch to venetoclax, if it is the disease is just like say diagnosed within few months and you have started, then definitely we have to give venetoclax. I had one more theoretical question in one meeting. They asked the patient is on acalabrutinib. Now it's almost 2-3 years, and the patient wants to stop the drug. He's fed up. He wants to stop the drug. What do you do? So
Yes.
at those situations also, we have to give venetoclax for at least say 6 months to 1 year. There is no definite guidelines, but give it for 6 months to 1 year, get them to some undetectable MRD, and you can safely stop acalabrutinib if you're giving this bridging therapy with venetoclax, sir. So the same thing holds good. As you said, if it's newly diagnosed and he has undergone this, he needs all these drugs, then better to switch to venetoclax-based therapy, sir. I agree, sir.
Yes, and about MRD, yes, with the BCL2 Of course, there is no discussion, but with the BTK inhibitor, small percentage of patients every year become MRD negative.
Yes, sir.
Based on your patient is 1 year, 2 year, 3 year on particular drug, if MRD has become negative, if you have a trustworthy MRD test available to you,
then you don't need to bridge.
Become negative, then you can very comfortably stop
Absolutely.
for a good duration. Dr. Gopinathan?
Yeah. Good afternoon, sir. I think it was an extensive lecture covering all the aspects of BTKi. So I just have one patient of Waldenstrom's who's relapsed Waldenstrom's. And he is MYD88 mutated and CXCR4 also mutated. So I just started him on acalabrutinib. How should we drive the duration of acalabrutinib in such patients? And rituximab, how much frequency of rituximab is what you offer to these patients?
So thanks, Gopinathan. So for this patient, I would suggest giving acalabrutinib indefinitely, Gopinathan. I would not suggest to, because it's a relapsed refractory patient, I would suggest to continue acalabrutinib. If he's responding well to acalabrutinib, there is no need to add rituximab is what I feel. So only in one trial they have seen ibrutinib rituximab and they compared it to rituximab alone. They have not compared ibrutinib rituximab to ibrutinib and shown that that combination is very much superior. So I think single agent acalabrutinib is sufficient, though it is not FDA approved because we don't have any phase 3 trials, randomized trials with acalabrutinib. I think it just acts like zanubrutinib. So in this patient who has both CXCR4 mutated and MYDP mutated patient, I think relapsed patient, better to continue acalabrutinib indefinitely till progression of the disease or whatever.
Right. Yeah. Suppose if I have the disease spike coming back, like if the response goes to less than partial response, and what would be your second go to? Because already this patient is exposed to BR. So what would be the second line or third line agent I would put it?
Until we get non-covalent BTK inhibitors, it will be difficult, Gopinathan. We have to just use the routine chemotherapy, chemoimmunotherapy. But usually patients with mantle cell and other lymphomas, we have seen who progress on BTKs, they go down very fast also. That is one disadvantage BTK inhibitors, especially mantle cell lymphomas. When they progress after BTK inhibitor failure, they progress very fast. So you will have to think of something aggressive only.
Yeah. So mantle cell lymphoma in 65-year-old above, but reasonably fit. So would you go for a chemo-free approach in that patients?
I'm still not confident to go to that. If they have comorbidities, frail, definitely I will try that, Gopinathan. But for young patients like this, 65 fit patients, I would at least go for the routine chemoimmunotherapy with ibrutinib. If you're not contemplating in the triangle study, give RDAP with ibrutinib and alternating with RCHOP. Put them on ibrutinib maintenance and rituximab maintenance. When I say ibrutinib, acalabrutinib.
Okay. Thank you. Thank you.
Gopinathan, again, I have two comments. What was your duration of chemoimmunotherapy for Waldenstrom before the patient developed resistance?
Sir, it was actually very short. After chemoimmunotherapy, within 3 months, he had a rising M band.
Within 3 months, he relapsed.
Yeah.
A rising M band, or he had indications for treatment?
So rising M band plus numbness. He used to have typical ear block and numbness because of the hyperviscosity. So that was actually the indication for treatment.
All right. And your second situation, elderly person with mantle cell, initial treatment of 2 months with the BTK, venetoclax, rituximab, putting the patient into sort of almost complete remission, and then followed by whatever chemotherapy protocol you give for 6 months, whether it is exactly what Satish has described, can make your job very easy, and you are able to cut down the chemotherapy doses, etc., also as per tolerance, with excellent results, followed by then 2 years of maintenance. So initial 2 months, this is MD Anderson, 2 months of these 3 drugs, no chemotherapy at all. And that's not only for elderly, for everybody. 2 months, you use only the targeted therapies and the immunotherapy. And then get on to this. Probably there is no then need for doing any autologous transplant at all in these patients. And that's reasonably mature data now. Good number of years, 4 or 5 years.
So can we give just bendamustine rituximab, sir, after this 2 months of targeted therapy?
Yeah, it's okay. He's a 60, 70-year-old man. So as such, you are going to use maintenance therapy with this initial months of this. In between, you can use whatever you want.
Excellent, sir.
Thank you.
We'll go to some more questions from the chat box. So when you compromise the doses of BTKi, does it increase the chance of resistance? Is the question by Dr. Shyam.
So we are taking a chance there. So as much as possible, we don't decrease the doses of BTK inhibitors only when those special situations, and as I said, when they're well into the treatment, and as Sir said, if they have achieved some sort of remission, then you decrease the dose. Definitely it will compromise, but we need to keep a close watch on the thing. But just because the dose is decreased, the mutations will not come up, the efficacy might go down. So if you see that the efficacy is going down, then you have to increase the dose or shift to, because what is the reason for decreasing the dose, that we need to see and counteract.
Another question from Dr. Wang is, what's your opinion about combining Zen with CYP3A4 inhibitor like azoles?
So with zanubrutinib, again, the inducers, if you use inhibitors, we have to decrease the dose. If you use inducers, you have to increase the dose of zanubrutinib is what is recommended, sir, as per that chart of drug to drug. But I'm not sure with which azole, how much it is, but there are recommendations or guidelines for zanubrutinib also when we use these drugs.
So next question, partly we have discussed, is from Dr. Sham. If cost is not an issue, what will be your choice for newly diagnosed 50-year-old CLL? And what will be your choice for newly diagnosed 50-year MCL? Do you ever use autologous transplant today in MCL?
So it is going out of fashion, as Sir said, but we are waiting for more data. 50-year-old today, definitely I'll add a BTK inhibitor along with my chemotherapy, talk to the patient about the options of skipping transplant and going to ibrutinib maintenance and rituximab maintenance versus doing transplant. But whatever it is, I think we should add BTK inhibitor like acalabrutinib during induction and post-transplant or without transplant maintenance. In CLL 50-year-old, as I said, again, we need to look at the status of TP53, mutated, unmutated, and then decide what is the best treatment. Again, in CLL, we are moving away from indefinite therapy to fixed duration treatment, except for the subset with the high risk subset with TP53 or 17p deletion.
Okay, Dr. Mallikarjun had also asked this question, and this comes up in practice with all the physicians. I would just have few remarks here. When you are choosing between BCL2 plus a anti-CD20 like obinutuzumab versus just a oral therapy, patient's preference will be very important, because obinutuzumab, one, because it will require hospitalization for injecting at least the initial doses and then injectable therapy for 6 months. Two, the cost of the drug, because it is still only the innovator. Three, the patient must have normal renal function, because venetoclax will lead to problem even if you are giving it after 3 months of obinutuzumab. So tumor lysis, etc. Again, hospitalization, availability of yours to monitor that, etc. is required. And four, whether there is a risk of infection, because main complication of venetoclax is it's extremely difficult to tolerate the doses without neutropenia. So if the patient is prone to infection, he's got an underlying, say, pulmonary disease, bronchial asthma, interstitial lung disease, bronchiectasis, or some recurrent urinary tract infection, then these are patients which are a bit dangerous with the venetoclax. Even with 100, 200 milligram, they get into neutropenias. So all those factors plus cardiology, of course, we have discussed a lot. Those patients you may not like to give the BTK inhibitors. And so there's a lot of practical discussion with patient and the physician of what will suit which patient.
Yes, sir.
The next one is from Dr. Malini. What is your experience of richer transformation when patient is already on ACALA in CLL?
So Richard transformation, doctor, is still a very bad disease. Unfortunately, there is no standard of cure. We need to go for some transplant. There is one trial with pertubrutinib in Richard's transformation. Due to lack of time, I didn't show that trial, but they did have some responses. But the 1 year progression-free survival, or at least only 10% of the patients were free of disease at 1 year. So pertubrutinib is coming up with Richard's as an isolated agent. This is the phase 1 or phase 2 trial data. But we cannot give only BTK inhibitors and stop there. We have to go for a transplant, preferably allogenic transplant. It is still a very bad disease.
One more comment, Dr. Malini. As I said in the beginning, I don't know whether you had logged in that time or not. My patient with Richter syndrome went for CAR T in Israel and is disease-free for last about now 4 years. This happened in the COVID, so 2025, 5 years almost, this patient is disease-free. And I firmly believe that Richard does not have a medical treatment at this stage. And transplants also, the outcomes are not so great. And in TP53 mutated disorders, CAR-T is the answer. So mental cell, TP53, richer transformation, CLL. We don't have this in our country, so they will have to go abroad. The cost will be huge amount, but nearby countries like China, Singapore, some of the patients are easily able to afford. Next question is, any scope for ibrutinib still when Acala is available and cheaper? So we have discussed that. Yeah, we have discussed that. Another question is from Handa. Thank you very much for comprehensive lecture. When will you suspect BTKi resistance and do the mutation analysis?
As of my knowledge, no one is doing mutation analysis in India, as of my knowledge. But you do suspect when suddenly a patient on BTK inhibitor starts, the WBC, the lymphocyte starts increasing, the patient develops type B symptoms, the lymph nodes start increasing. So typical, all those relapse features when they come in the labs and clinical features, you should suspect whether you have developed. First thing is you need to ask the patient whether it is complaint. Most of the patients, they'll not be complaint. Once you rule out non-complaints, you have to suspect resistance. And if hopefully soon the mutation profile comes up, we need to check the mutations.
Thank you. The other one is from Dr. Bharat. Mental cell lymphoma, CNS relapse. If you are planning a BTK inhibitor based regimen, that is IBRU, then what will be the combination?
This patient is a treatment naive patient?
No, relapse.
Relapse patient. So, I mean, it's a bad patient. So, ibrutinib with, I'm not sure. We'll have to see what patient has received in the past and then plan the treatment. But it has to be an aggressive. Only BTK inhibitor will not help. And these patients, as Sir said, they don't do well. You have to give some cellular therapy, whether transplant or CAR T cell therapy. They have to go for that. What combination with BTK inhibitor depends on the prior treatment. So if they've received R-CHOP or the autologous transplant, you need to change gears and go for a more aggressive therapy. Like I'm not sure whether if the patient has TP53, chemo will help him. So there is one combination of zanubrutinib, venetoclax, obinutuzumab in TP53 positive patients. You need to try those things, zanubrutinib, obinutuzumab, and venetoclax, and see whether, I mean, again, zanubrutinib does not have so much of CNS penetration. So you have to add a BTK inhibitor with this combination and try to get them into remission and go for a cellular therapy. Sir, any comments, sir?
No, I agree with you that these are very bad patients. We treat them like lymphoma patients with CNS involvement. So intrathecal, high dose methotrexate systematically, dexamethasone, and those BTK which can penetrate the CNS use it, but the outcomes are terrible. You're absolutely right. Now, Radhika is asking a question that in a patient who has presented with Bing-Neal syndrome, IBRU is recommended and not Acala. Why?
That's because ibrutinib has a better CSF penetration than Acala. So ibrutinib, if ibrutinib is not available, zanubrutinib. Acala, the CNS penetration is not much. That's why they've recommended that. So there's no much data, unfortunately, phase 3 trials with Acala in Waldenstrom's, though they're coming up soon. So in this Bing-Neal syndrome, right now, the drug of choice is ibrutinib, even compared to zanubrutinib.
Dr. Divya, your question.
Good morning, sir. And that was a wonderful talk, quite comprehensive on BTK inhibitor. Sir, I would like to get your opinion on an elderly DLBCL patient, more than 60 years, who has completed CHOP. Would you consider a BTK inhibitor as a maintenance?
Definitely not, Dr. Divya. With the data available, there is no advantage of giving BTK. There are very, very small subset of ABC DLBCL where it has shown some promise. But until we confirm it with further trials, at this point of time, I would not suggest to add BTK inhibitors.
Okay, thank you.
Yeah. So if your patient can go for genomic studies on the block at a center abroad, then you have that subset which can be picked up.
Yes.
Then you can probably right from the beginning add R-CHOP plus X that we talk about. Then the X will become ibrutinib there right from beginning. But then you should get the genomic studies done on your paraffin block for that patient.
Thank you, sir.
Thank you. One more question has come up. Is an 80-year-old CLL tuberculosis has got activated on Acala. Can I continue Acala?
This patient definitely with TB on board, it's difficult to switch therapy. So I think we can definitely continue ACALA. Just keep in mind the drug-to-drug interactions and see whether if the disease is in remission, we can cut down on the dose. We have to act accordingly. Just to keep in mind the rifampicin and other drug-to-drug interactions. We need to check how it will affect the acalabrutinib dose. Otherwise, I think this patient, such an elderly patient, continuing BTK would be the best choice.
That's the last question. So, Satish, thank you so much. Wonderful talk and then great QA session. You are with us for last 2 hours. Extremely grateful to you.
Thank you, sir. I hope I did justice to the topic. Thank you so much.
This will be extremely useful, not only for the students and fellows and trainees, but also for all the consultants across the world. So hard work put in. I really appreciate it. You've done a wonderful job this afternoon. Thank you.
Thank you so much, sir.
Bye-bye to everybody. And do we have INTAS people here?
Yes, sir.
Please go
Thank
ahead
you.
with your official vote of thanks.
Okay. Thank you. I really like to thank you, Dr. MB Agarwal, sir, Dr. Mukul, sir, Dr. Satish, sir, Dr. J.M. Kunga, sir, and Dr. Krishnapna, sir. And I would like to thank everyone for sparing time on this Sunday for this excellent session. So with that, I would like to thank everyone. Namaskar.
Thank you for being with us and supporting our activities. Thank you. Bye-bye.
Thank you, sir. Thank you, sir. Bye-bye.
Yes, again. Bye, everybody.